Hey everyone, welcome back to another brand new exciting day here on Doctors Go Live, a brand new episode with me, your host, Nina Cheryl Khan. And today we are going to be talking about heart attack, recognize and respond fast. Okay, so if you're tuning in right now, let us know who's tuning in and where are you tuning in from? And of course, what would you love to learn in today's episode of heart attack, recognize and respond fast? All right, and of course, if you share this video out, you get to take part in our Doctors Go Live quiz happening right at the end of our show after the Q&A, and you get to win some really exciting prizes up for grabs. All right, all this is happening right here on Doctors Go Live with me, Nina, and our special guest for today, Dr. Kogulakrishnan Kaniappan, consultant internal medicine and cardiologist from Columbia Asia Hospital, Klang. Now, all right. So heart attacks, right? It is one of the leading causes of death worldwide, and many people either miss the early signs or don't know how to react quickly. The good news is knowing how to recognize these symptoms and act immediately can make all the difference between life and death. So today we will be exploring the critical signs of a heart attack and guide you on how to react swiftly and effectively. So definitely this info is going to be super useful for everyone who's tuning in out there. And if you think it's really useful and it's really important for all the people out there, for your friends and family, it's going to make a difference to them, you know what you need to do. Be sure to share this video out on social media, tag your friends, follow us on our social pages, because it could make the difference between a life or death. All right, so while you are busy sharing our show today, let's take a quick look at this video.
Heart attack is the leading cause of death worldwide. Unfortunately, many patients do not know the early signs or unsure what to do when they develop one. The good news is knowing how to recognize symptoms and act immediately can make all the difference between life and death. I'm Dr. Krish, a consultant cardiologist and an internal medicine physician from Columbia Asia Hospital, Klang. Join me in the next episode of Doctors Go Live, where we're going to explore the critical signs of heart attack and the management that can help to save you and your loved ones. Tune in on next Wednesday, 13th of November 2024 at 3 p.m. This is a life-saving information that you don't want to miss. See you then.
Welcome back to Doctors Go Live. If you just joined us today, I have a question for all of you tuning in right now. Would you recognize the signs of a heart attack if it happened to you or to somebody that you love, right? Most of the time people don't understand or people don't know. So heart attacks can strike without warning, and knowing how to respond will make all the difference. So here to help shed some light on how to respond in a critical situation such as this, please welcome our consultant internal medicine and cardiologist from Columbia Asia Hospital, Klang, Dr. Kogulakrishnan Kaniappan, who's going to guide us through how to spot early symptoms of a heart attack and what actions to take. Welcome, Doc, to our episode today on Doctors Go Live. Thank you so much for joining us.
Hi, good afternoon, Ms. Nina, and good afternoon to our Facebook audience. It's a pleasure to be here.
Okay, now before we begin, audiences, as in every episode, right at the end of the show, we have our Doctors Go Live quiz where today we've got some wonderful prizes up for grabs. And most importantly, you want to pay attention to Doc here because he is the key to answering all those questions. Before that, and definitely please be sure to tag all your friends and family if you think this is an important message for them. Q Xing, Tan Q Xing, thank you so much. You tagged like about the whole world. Thank you. Okay, so of course if you have any questions as well, please just type it out in the comment section anytime you think of it, and we're going to address it and answer it with Doc's expertise. All right, can do. Okay, so Doc, before we start, let's start with the basic. Could you share with us a little bit about yourself, how you got started in medicine, and why cardiology?
Well, I've been always been interested in medicine since I'm a small boy, I would say. It amazed me when we are sick and we go to see a doctor. The doctor somehow magically knows how to treat you, and you recover just after seeing them. So I think as a healer, they have this special opportunity to make changes in someone's life. So that's how it started. So that's the reason I wanted to pursue medicine. While in university, I started to love cardiology in particular because cardiology, as a subject itself, it is very complex as well as is very unique in a way that it is what matters the most. And of course, we all know what matters the most is your heart, and it's been something that has been interest me all throughout, and that's the reason why I chose cardiology. Because end of the day, I feel as a cardiologist, not only you save life, you make a difference in someone's life and their family as well.
Right, okay, so I guess you are a heart doctor, right, Doc?
Yes, yes, of
And
course.
you're an expert in matters of the heart, right? Okay. So, Doc, why is it important that we talk about today's topic? I mean, what are you hoping that the audience will take home?
I believe everyone knows what is heart attack, and most of us knows that. I'm sure you have known someone in your family, your friends, or your family of your friends who passed away because heart attack. But we never take it seriously because we always believe it's not going to happen to us. But it is very important that for us to know that the cardiovascular disease burden is very high, not only in Malaysia, worldwide. And that is why I will show you in our statistic that it is the leading cause of death, not only in Malaysia, but also worldwide for more than a decade. Despite the advances in technology, despite many new medical treatments available, it remains to be the leading cause. One, because the lack of awareness among the public. Number two, the urgency of the matter. They always present to the hospital late. So that is another reason. And knowing the risk factors that leads to coronary artery disease also helps to prevent the disease. So I hope at the end of this talk today, we can educate our audiences regarding the reason why is it important, how do we take care of ourselves, what are the risk factors. If you have any of these risk factors, that you must seek medical attention quickly to reduce the risk of you developing coronary artery disease. On top of that, if you have any of the symptoms that we're going to discuss, then you must immediately seek medical attention to your nearest cardiologist or a physician at least.
All right, got it. I think, are you guys getting the message? Let us know in the comment section. We would really love to know. So, this is serious. It's not just a matter of the heart, it is still the number one leading cause, yeah? Despite advances in technology and medicine. So, let's get straight into this, yeah, Doc? So, Doc, is what can go wrong with a heart? Is every chest pain a heart attack, basically? I guess that's what we think it is, right?
This is why I feel the heart is very unique and complex because one does not only have coronary artery disease, there's many things that can go wrong with your heart. Besides coronary artery disease, one can also develop rhythm problems like slow heart rate, very fast heart rate, which can present with palpitation, giddiness, dizziness, and fainting episodes. Some can develop valve problems where they have to go for valve surgeries. And there are also a large population of our Malaysian public who develops heart failure. where they present with shortness of breath, leg swelling, and many other problems. And of course, you can also get infections in your heart.
Okay.
But our focus today will be heart attack because I think that is the most important one that we need to discuss today.
Okay, got it. All right. So I guess we got to go back to real basic. When we talk about heart attack, what exactly is it and what is coronary artery disease?
Coronary artery disease, as the name suggests, simply means there is a disease in the coronary arteries. What happens is your heart acts like a pump that pumps out blood to all over your body. So,
Mm.
as a pump, it works depends on the myocardium, the muscles of the heart. So, it requires blood supply. So, the blood supply to the heart is by the three major arteries in your coronaries in your heart, which is your right coronary artery, left anterior descending artery, and the left circumflex. From there are many branches which actually covers the whole of heart. So whenever there is a disruption of blood flow in one of these vessels, be it large vessels or the smaller vessel, this will actually translate in reduced oxygen supply to the particular muscles. And sooner or later, this muscle will have lack of blood supply and started to die. So the dying of muscles, that is what we call as cardiac damage. And this is where a patient will experience pain, the chest pain. The
Mm.
severity of the disruption of blood flow will also translate the severity of disease. Meaning, if it's just an occlusion of a smaller vessel, you might have the pain, the ischemia, but this not lead to sudden death. But when a large vessel is occluded, a large area is affected, this is where patient can develop sudden death or can go into heart failure and many complications. So
Okay.
this heart attack is a very broad spectrum where it can be subdivided into many small, uh, few different categories, which we will discuss later.
Because, Doc, when we talk about the arteries being blocked, it doesn't happen overnight. It's kind of like a slow process until it gets really blocked and then cannot.
Yes, that's very true. That's very true.
So, is this what you mean by this?
Yes, exactly. So the coronary artery disease basically is a spectrum. So if you can see from what is the chart show, this is by the European Society of Cardiology and just recently published this year, July. Is the latest guideline where they talk about coronary artery disease being a spectrum of chronic coronary syndrome. What does this simply means that obstructive coronary artery disease where there's a blockages in the coronary artery is only a tip of an iceberg. But the problem starts way, way, way before that. There is also another part of coronary artery disease whereby there won't be a occlusion, then there wouldn't be a blockages in your large vessels. There might be some problems in your smaller vessels, whether the vessel constrict, which we call as vasospasm, or the effectiveness of the coronary vessels is dysfunction, which is we call as microvascular dysfunction. And there's also another component where we call this as INOCA. INOCA means ischemia with non-obstructive coronary artery disease, where when you do an angiogram, you might not see a occlusion, but when let's say the same patient still presents with chest pain, then you wonder why this patient presents with chest pain. So the problem is not in the larger vessel, the problem is actually in the smaller vessels of the heart, which cannot be seen on a naked eye in your coronary angiogram. This is where you need some other imaging modalities such as MRI to prove what is going on, or a PET scan which will identify these problems.
Mm, okay, got it. All right. So, I guess what's this one about? If you can share with us, Doc.
This is basically to highlight how does the heart attack happens. So when you
Mm.
have a coronary artery disease, meaning when you have a vessel which has been a smooth flow, there is no traffic in that blood flow. So slowly, gradually, there is a build-up of plaque, means build-up of lipid fatty plaques over the time with calcium accumulation and macrophages. Over the time, this will build occlusion. So as the plaque build up, the lumen of the vessels becomes smaller and smaller. So the blood flow is becomes slower. At one point, when the occlusion becomes as big as the whole vessel, it occludes the vessel. There is no direct flow. So whenever there's no flow, there's an obstruction of flow. What happens is patient develops severe chest pain because that particular area which is supplied by the blood vessel has been cut off from blood supply. So this is where they develop a severe heart attack. So heart attack can be a mild occlusion, moderate occlusion, or major occlusion.
Okay, got it. Cool. So if you have any questions, like some of our people, Ailian over here, Ritalia, if you have any questions, just let us know in the comment section and we'll answer it at the end of the presentation. So let's talk about symptoms. Yeah, Doc. What are the symptoms of ACS?
I think many believe the heart attack always presents with chest pain. It's true, chest pain is one of the common presentation for heart attack, but a person who develop heart attack, some problem with supply and demand, whereby there is a blood flow is disrupted to the heart, they can also present with upper body pain, radiation to the left upper limb, or it radiating to the neck or to the back. Sometimes they have very unexplained shortness of breath. They might have lightheadedness, dizziness, and some can even have a sudden fainting. And this can be associated also with diaphoresis, where there will be a profuse sweating. They have chest pain with profuse sweating, or they feel anxious knowing that something bad going to happen. So does not mean that if you don't have chest pain, you're not dealing with a heart attack. So as long as you feel unwell and you think that something's wrong, you must immediately seek medical attention just to make sure this is not from the heart.
Okay, got it. So when is it that we need to be very worried, Doc?
So
Yeah.
this is what has been suggested or advised by the American Heart Association. They have listed down some common heart attack warning signs. This could be what I would say red flags. If you have these red flags, you must immediately seek medical attention, possibly in a center where the cardiology services are available. Otherwise, to the big hospitals at least, or if it's very distant, at least to the nearest medical attention. It could be a clinic kesihatan, or it could also be a GP. Anywhere, as long the doctor can immediately attend to you. So number one is of course chest pain or discomfort in your chest, which may or may not radiating to the left upper limb or neck. Number two, you might feel nauseous, or you want to vomit, or you feel a bit tipsy, lightheadedness. You can also experience some pain in your jaw, neck, or to the back. And of course, some discomfort to the shoulder. And do not neglect the fact that some people only present with shortness of breath. They might not have any chest pain, they just feel short of breath, and that could also be the early sign of heart attack.
Okay. So we need to take note of these five lah, yeah? Okay. What about for women? Is there a difference between the symptoms?
I would say generally the symptoms can be the same for women, but there are also a population, women middle age and all that, who can present with very atypical symptoms, whereby they might not have the typical chest pain. They might present with a stomach pain. They might come with just palpitation or giddiness. They might have shortness of breath. And on top of that, the spectrum that I've shown earlier, that I mentioned, there's one group of patients who have obstruction in the blood flow, another group where there might be some vasospasm, some constriction of blood flow, or blockages in a smaller vessel. So this is more predominantly occurs in women for some reasons.
Okay. All right. Good to know, Doc. All right. So now I guess we come to the most important. But before we do that, yeah, Doc, what is this slide about?
So this is the slide taken from the one of the journal from Jack. Actually, they are stating that what are the top 10 causes of chest pain that patient present to emergency. So as I mentioned, not all chest pain is cardiac in origin. not all chest pain are heart attack. But at the same time, you would not be able to differentiate them if no further investigation done. So there might be some blood tests need to be done, some imaging, some ECG to be done to make sure this is not heart attack. Because beside heart attack, what other problems that can present with a chest pain? You can might have a reflux problem. You might have a gastritis that presents as a chest pain. You might have lung issues, asthma, which can present as a chest pain, asthma attack. You can also have some panic attacks, anxiety, or some rhythm problems where they present with the chest pain. So there are many causes of chest pain. So it's important for us to differentiate them. And the only way to know that is by doing further investigation.
Okay, got it. So not all chest pains leads to heart attacks, but it's important to know what it is,
But the
right,
heart
doc?
attack is the most dangerous one.
Yes, got it. And patient current characteristics, yeah, doc.
So this is
Maybe,
the
yeah.
latest registry by the National Heart Association of Malaysia, which underscores the importance of knowing coronary artery disease. Because if you look at the summary, they mentioned that the Malaysian patients who presented with ACS are young. Acute coronary syndrome is heart attack are young. So it's no longer a disease of the old. We have patients as young as 20 years coming with a heart attack who require a stenting procedure. So, almost a quarter of patients who were admitted in Malaysian hospital for heart attack are under the age of 50, and this is alarming. And our population is young populations, and of course we are because of a good healthcare, people are living longer. But we tend to realize that many of our heart patients who die are also young patients. We have patients who are 40 years old, 50 years old, who develop heart attack and couldn't make it because one, lack of awareness, number two, because they might think that they are young, they might not have any problems. So how do we know that you should need to get a checkup done? Some of the clues would be if you have a diabetes, you have hypertension, dyslipidemia, or any of the risk factors that we're going to discuss later, you should always make it a point that you do an annual checkup or medical checkup every 1 or 2 years.
Okay. Annual checkup, is that enough for you to kind of detect it early that you could be at risk?
If you do not have any symptoms and you just want to make a screening procedure, annual cardiac checkup would be something that I would recommend. But if you have
Mm,
symptoms, just a mere checkup might not be enough. You need further investigations.
right. I think because Malaysians, we are terror, right? And especially we're terror when it comes to food. I think good lah to have annual cardiac checkup
We love
kind of
our
thing.
food, right?
Yeah, definitely. That's one of the things we're very proud of, kind of thing. All right. So this is patient characteristics. So now we talk about risk factors here. What are some of the major risk factors for heart attack? Are there any lesser known factors that people should be cautious of? Or maybe we start with the basic because we're not aware,
Yeah, of
right?
course. There are many risk factors for coronary artery disease. That means
Mm-hmm.
if you have these diseases, it actually gives you a higher chances of developing coronary artery disease in the near future. And there are
Mm,
some that you can change, some you could not. And it is called non-modifiable risk factors. Is something that you cannot change. You cannot change your genetics, you cannot change your inheritance, and of course age and gender is something that is beyond us. But what you can change is you can quit smoking. If you are smoking all these years, probably it's time for you to quit smoking, and that definitely will help. And of course, if you realize if you have a high blood pressure, and making sure you are under treatment with a doctor helps. And of course, not only on treatment, you must make sure it is under control and under the target that we aim to. Similarly, if we have a high cholesterol, we have diabetes, this is also important for us to control because these are the diseases, the three most common diseases: diabetes, hypertension, and high cholesterol, which leads to coronary artery disease. And since lately, since COVID, many of us are working from home. We have no time for exercise. We are in a our lifestyles has changed so much that people are very stressful, lack of time for exercise. So sedentary lifestyle is also not good.
mm. Okay.
So these are the things that we usually advise our patients, things that you can change, the risk factors that you try to modify.
Okay. And Jesse Liu says change lifestyle and diet.
Yes, that's very important.
Okay. All right. So, Doc, how do we know for sure? Okay. So, when we have that warning signs, we send straight to the nearest medical facility, right? How do you know for sure it's a heart attack? How do you diagnose it? Maybe you can walk us through that.
Okay, to diagnose a heart attack, there will not be just one test to confirm heart attack. You may require some. So there are many different variants of heart attacks, right? Which I will discuss further. If you have a major heart attack, meaning what we call as ST elevation MI, myocardial infarction, which is the most dangerous one, which is a matter of urgency. So the only test that we do is the ECG. Based on the ECG and based on the changes in the ECG, ST elevation in the ECG, and the presentation of chest pain, this we confirm whether this patient has a severe major heart attack, which we call a ST elevation MI. And this one is a matter of urgency where this patient will be directly pushed for a urgent angiogram and angioplasty to establish back the blood flow, which was occluded fully. If not, the patient will not make it. That is the most severe heart attack. What about the one with the mild ones? So for
Mhm.
that, we might need blood tests, which we most importantly cardiac enzymes, right? And of course, echocardiography will also help us to identify whether this patient is having a heart attack because there might be a lack of movement of one segment of the muscle, which also gives us a signal to say that that area probably is lacking of blood supply or having a ischemia. And of course, a patient who comes with stable heart attack where the blood enzymes are normal, right? ECG did not show any changes, and echo may or may not be abnormal. Then we have to investigate further, bearing in mind, as I mentioned, not all coronary artery disease comes with a total occlusion. There could be also some minor occlusion or occlusion of the minor vessel. So how do we identify them is by doing some extra tests like a treadmill stress test. We might need to do a CT coronary angiogram and of course the others, nuclear scan and MRI.
Okay.
And
So, there's
based
lots.
on the patient profile and the diagnosis, we have to decide whether this patient will require urgent angiogram or something that we do it later.
I see. Okay. So there's a lot and multiple tests to determine, right? Doc, just out of curiosity, let's say somebody you know or you think you having a heart attack. So the best thing is to send them to the hospital. But is there a lot of truth? People say that they take time, they dilly dally. Does that also happen?
I think if you're having a heart attack,
Mm,
if it's possible, get someone to drive you to the hospital rather than you driving yourself because that can be dangerous. And if you have someone who have a aspirin, blood thinner medication on board with you, probably you can take it as an emergency pill or another pill that you put under the tongue, which is called a GTN, sublingual GTN. Is also something that you can help. It's a lifesaver for the transient movement before you
mm,
reach to the nearest hospital. So when we talk about severe heart attack, which is your ST elevation MI,
mm-hmm.
time is we call it in cardiology, time is myocardium. Every minute that you delay, there is a high chances that you may uh, have a
Die.
very bad outcome, which including dying, right?
Okay.
I wouldn't say dying straight, but bad outcome. The outcome changes every minute. So we usually say when you have a major heart attack, right, you
Mm-hmm.
need to go to the nearest hospital as soon as possible. Possibly to a hospital where the cardiologist is available, where they can perform a urgent angioplasty if indicated.
Okay.
Otherwise, if you at least go to the nearest doctor that you can attend to you. And if
Mm,
it's a major heart attack, which is a STEMI, right,
mm,
it's a matter of time. If you
mm.
are in a center where the cardiology service is available, we need to perform the angiogram within an hour. if let's say you are in a center where the cardiology service is not available, then the emergency doctors have to make a decision. Number one, if you think you can reach a cardiology center within the next 2 hours, then you transfer them to that facility. Otherwise, if you think there will be a delay, then we give them a medical treatment which is called thrombolysis first
Mhm.
to stabilize
Mhm.
the patient. So these are some of the guidelines which has been put in place not only by Ministry of Health but also recommended by the European and also American cardiology societies.
Okay. Thank you
And this
very
is
much.
this
Yeah,
is
I
for the major heart attack. So you'll never know you're having a major heart attack or minor heart attack. The only way for you to know if you go and check yourself. So if you
mm,
sit at home and thinking that this is just a mild heart attack, you're probably denying the truth. And
mm,
there's a high chance you may just collapse at home.
mhm. Okay. So I guess it's better to be safe than sorry, right, Doc?
True.
Okay, got it. And of course, if you have your consistent checkups, that will kind of give you an indication and you can intervene things before it gets to that level, right, Doc?
So prevention is always better than cure, right? So
Yeah,
good to do
definitely.
the screening. Yeah.
Yeah, okay.
And
So
this is
let's.
exactly to highlight what I mentioned just now. You
Mm-hmm,
can A chest pain which is cardiac in origin can range between a stable angina,
mm-hmm,
yeah, or unstable angina.
mm-hmm,
So you can have a stable coronary artery disease where there is a occlusion, but there is no sudden disruption of blood flow. The disruption of blood flow has been there very gradually. So you might have some pain, but the pain does not cause you harm at this point of time. But there's also a disruption, there is already a narrowing, and there's probably add on that there's a new narrowing there which cause a sudden extra occlusion. So this
mm,
is what we call acute coronary syndrome,
mm-hmm,
where it can be unstable angina, which I
mm-hmm.
can show you in the next slide.
Okay. Do we go to the next slide? This
The
is a
next one.
stable. Okay.
Yeah. So this is unstable angina. As you can see here in the vessel, there is some stenosis and a small plug rupture. And this ruptured plug might go distally to a smaller vessel and cause an occlusion, and that will disrupt the blood flow to the smaller part of the vessel. And probably that part of the muscles have pain because lack of blood supply. So
Okay.
if you do an investigation for this patient, you might have a normal ECG, or you might have some changes like inverted T, acid depression, but the cardiac enzymes are normal. So we label them as unstable angina,
I
and we
see.
initiate treatment to them
Okay.
with medical treatment first and probably angiogram later if is
I
indicated.
see. Okay. And this
So
is what a stable angina looks like. Yeah.
this is stable. The next one is unstable. So the following one is non-ST elevation MR. This is something is very important for to know is that not only does ECG changes, there is evidence to say the muscle is dying. There's a subendocardial infarction. Infarction means there's a death of the muscle. So the longer you delay, this will lead to probably STEMI or something later. So a patient with non-ST elevation MI, there is a myocyte or cardiac muscle damage. The cardiac enzymes will be raised. So based on this finding, we label them as non-ST elevation MI, which warrants medical therapy as well as angiogram and angioplasty.
Oh, okay. Got it. And this one?
And this is the major heart attack. That one that mentioned to you that you have to be in the hospital. Some treatment has to be administered within 1 hour. If you're in a cardiac facility, you need to go for
Mhm.
angio because you can see there's a total damage of one part of the muscle, which is shown in the black picture there. The muscle
Mhm.
transmural infarction means the whole muscle has been dead, is all dying. The longer we wait, the damage will extend and patient might not survive.
Okay, got it. So this is the one that we want to avoid, right? Okay. So I guess there's lots of tests. Which are the tests to do, right, Doc? Is this what this is about? Mm.
So, how do we decide which patient goes for what test? It all depends on the patient profile. As you can look at a pyramid, the base of the pyramid say asymptomatic, right? So someone who does not have any symptoms coming for a checkup, how do we decide what test we do? So based on their risk profile, we look at their background, whether they have any family history, do they have dyslipidemia, do they have high probability of getting a coronary artery disease. Depending on that, we choose what would be the test of choice to confirm whether they have a coronary artery disease. So either they can go for a stress test, stress echo, CT scan, MRI, nuclear scan, so on and so forth, right? But as the patient goes at the top of the pyramid, which is your low risk, intermediate risk, high risk, and acute coronary syndrome is the topmost, is the summit, right? The urgency of the matter becomes our most important key. So we do not wait doing testing. They might need to go for urgent angiogram itself.
I see. Okay, got it. Okay, so these are the other tests you were talking about, right?
So these are some of the functional tests. So when we talk about investigation to know whether a person has a coronary artery disease, meaning we want to know whether there's any blockages in your coronary vessels, there's two ways we can do. One, we divide it into non-invasive. Non-invasive simply means that we don't put any wires into your body. There is no long tubes through your artery. It's all through externally. We ask you to run, right? And based on the ECG changes, we can make decision whether there is any abnormal changes in your heart.
How
And
long is a run, doc, for these tests? Just
it
wondering.
depends. It depends on how fast they reach a target heart rate. So there's a few things that we look into. We look into the blood pressure changes. We look into the heart rate changes, the ECG changes, as well as whether this patient able to achieve a certain target heart rate according to their age. If they do not achieve the target heart rate for whatever reasons being, probably they have knee pain, they feel fatigue, then these test results will become inconclusive, will not be able to confirm whether they truly have the problem or not. Then we might suggest some other modalities. So for me, I usually ask patients, do they have any knee pain? Elderly patient, they might not be able to do treadmill, right? So there are other types of tests that we can do. We can ask them to go for a dopamine stress echo. We can ask them to go for an MRI or CT, depending on what we need to choose. So there's not one test that fits all. That's what I'm trying to say. It has to
Okay,
be tailored to the individual patients.
okay. And this is a stress echo diagram?
Yes. So
Right.
stress echo can be done in two ways. One, by running, which is treadmill, right? Number two, by giving some medication to make the heart beat faster. So while the heart beat faster, we look at the movement of the muscle before and after the patient exercise, or after the heart goes faster. So we want to know the performance of the heart remains the same, or there's any reduction in the performance of the heart. If there is a reduction in the performance of heart, it actually indicate there is a problem of the blood flow, which translate into a possibility of coronary artery disease. And we will advise this patient to go for an angiogram.
Okay, got it. And this is a nuclear stress test.
Yeah, this is something that we usually suggest for patients who have kidney problems, because sometimes we cannot ask them to go for an MRI or CT scan because of the issue with the contrast. So this will be a good option for this group of patients where they are looking at the perfusion. Based on these charts and illustration, it actually can tell you which area of the heart is lacking blood supply.
I see.
And
Okay.
why would an area lack blood supply? Most likely there might be an obstruction in that particular area. So that
Okay.
is how we make that decision.
Okay, got it. And this one?
And this is your CT cardiac, which gives you a very beautiful picture. You can actually have many sections. You have a sagittal, axial, many views, which using your processing, you will get a 3D picture as well to look at the lumen of your coronary arteries. So we
Mm,
will see whether there's any occlusion or narrowing in the lumen. And based on that, we classify them either a minimal disease, mild disease, moderate or severe disease. Someone with a moderate disease is most likely have to go for another functional assessment to prove whether there's a ischemia or not, if they have symptoms. Otherwise, the moderate severe is something that we suggest to do a cornea angiogram just to rule out whether they have a large vessel coronary artery occlusions.
Got it. And this is the MRI.
MRI. So MRI also look at the perfusion. This is one of the very good imaging modality which will tell you whether the perfusion at some areas or any area of the heart is lacking. So when there is a reduction in perfusion, this is what we call as ischemia. So we want to look for ischemia. So these are the tests that we use to identify whether a patient has ischemia. Then we classify the ischemia into whether this patient has small ischemia, small stress-induced ischemia, or moderate stress-induced ischemia, or large stress-induced ischemia. So this amount actually translate into possibly the amount of blockages that the patient has. If the occlusion is large, moderate, or mild.
Okay, got it. Doc, so earlier you spoke about angiogram and angioplasty, right? What exactly is it?
I mean, as I mentioned earlier, there's two ways we can identify a patient whether they have a coronary artery disease. The first one is the one that I've shown you. All those are non-invasive modalities whereby we don't put any wires or tubes into the patient. It's non-invasive. Having said that, it is good enough to diagnose the problem. But if you want to solve the problem, beside medical therapy, some patients may require angioplasty, which is a stenting procedure. So this is where your angiogram and angioplasty is important. And of course, there's also a certain group of patients where we think they are very high risk or they present with a non-ST elevation MI or MI. We don't do the non-invasive. We straight go for a angiogram procedure. So basically, what we do is we cannulate the arteries in your hand or in your femoral, and we introduce a long tube into your vessel all the way to the aorta. And from there, we inject some dye which will flow into your coronary arteries. And this is something that we view using a live X-ray, which is called fluoroscopy. From there, we can actually determine whether do you have significant occlusion or not. If there is significant occlusion, then the question is how many occlusion do you have? If we have multiple occlusion, and based on the patient profile, then the decision would be, should you go for a bypass or is it going to be a stenting procedure? Usually, if a patient is diabetes and they have multiple occlusion involving the left main, then we have to give the option of bypass. And of course, there will be another option of multi-vessel PCN and all that, but it all depends on number one, how severe the occlusion is. Number two, how many occlusion there is. And number three, where is the occlusion? All these matters. And all this information can be gathered just by doing the angiogram.
I see. Okay. And I believe we have a video on the angiogram. Is that right, Doc?
Yes. Let's have a look now.
Okay.
Angioplasty, also called as the percutaneous transluminal or balloon angioplasty, is a treatment procedure to restore the blood flow in the narrowed or blocked coronaries caused due to plaques or blood clots. Most coronary angioplasty procedures last between 30 minutes to 3 hours. Once the patient is admitted, his heart is monitored and is given an intravenous sedative to relax the body. A needle is inserted through the wrist into the radial artery. A guard wire is then passed through the needle and is guided through the arterial system up to the heart. A flexible catheter is slipped over the wire and threaded up to the heart. This is monitored using a continuous X-ray imaging device called fluoroscope. At this point, the guard wire is removed and the tip of catheter is positioned to enter the coronary artery. A special dye is injected which allows the fluoroscope to take X-ray images of the arterial interiors and help in identifying the position of the block. This is called angiogram. Once the blockage is identified, a flexible guard wire is inserted into the artery vessel, followed by a balloon-tipped catheter over this wire to position itself at the site of the blockage. Rapid inflation and deflation of the small balloon pushes the vessel wall out, re-establishing the flow of blood in the artery. After the blocked vessel is reopened, the deflated balloon catheter is withdrawn from the artery. The same treatment procedure is repeated in the case of multiple blockages. Most patients may also receive a coronary stent, which is a small tube made of wire mesh designed to keep the artery open once it has been treated. A collapsed stent is placed over the deflated balloon catheter as it is inserted into position. When the balloon is inflated, the stent expands and locks itself into place. The deflated balloon and catheter are withdrawn, leaving the stent behind to hold the artery open permanently. Post-treatment, a pressure bandage is applied over the radial artery to prevent bleeding. One will need to lie down for several hours, during which signs of bleeding or chest pain will be monitored. The patient may either be discharged on the same day or after an overnight stay at the hospital.
I must give the credit to Fortis Healthcare. They have shared this website in their YouTube channel, which I find it very interesting. And this actually illustrates very clearly how the angiogram procedure is being done.
Quite clever and very, very nicely illustrated, I have to say. Very easy, right, guys? Okay, let's take a look at the next one. So we're going to be talking about treatment, yeah, doc. Is there any way to recover completely or halfway, or how does it work, doc? You can share with us.
I think when we discuss about treatment, we can divide the treatment into medical therapy or invasive therapy, right? Invasive means doing an angiogram and all that. But the medical therapy, of course, number one, before we talk about medication, let's focus on the general management. Of course, as one of our audience pointed out, diet and lifestyle is something that is the key strategy for us to prevent coronary artery disease, as well as someone who have a coronary artery disease to have a stable lifestyle, right? Diet
Yes.
and lifestyle is very important. On top of that, quit smoking for those who are smoking. And besides that, it is also essential for us to optimize the risk factors. We have to make sure your diabetes is under control, your heart, your hypertension, your blood pressure is well under control, your cholesterol are under control, whereby your LDL is up to the target. If you have a kidney disease, make sure you are under a nephrologist care. Make sure that the renal deterioration it is not worsening. And one of the most important part is also look at your weight. Obesity also can lead to coronary artery disease in the long term. And not only that, it's part of a metabolic syndrome. So it's also important for us to watch our weight.
Okay, got it. And what about
This is
this one?
actually what it highlights here. Healthy diet, avoid alcohol, lose weight, check your blood sugars, check your blood pressure. Of course, exercise is important. And a good sleep is a must. At least 7 hours of sleep quality of because lack of sleep, stress also can translate into many things. You have a high blood pressure, sugars might not be well controlled, which on the long term translate into coronary artery disease.
Okay, got it. Okay. And what about for this management?
So this is where your acute coronary syndrome, which is your broader term of heart attack is. So depending on the type of the heart attack, which is the major heart attack, which is your STEMI, patient goes for an emergency coronary angiogram, and we have to do angioplasty procedure to establish back the blood flow, which is disrupted, either by doing a PCI, which is your angiogram, or a place where the cardiologist services not available, they have to give medical treatment to treat the blood flow disruption via a thrombolysis, right? And once that done, we continue medical therapy in the ICU or CCU setting. The second one is a non-ST elevation MR, which is not as severe as the first one, but also requires an early angiogram. Usually, if the patient have chest pain and ECG changes, and we notice the cardiac enzyme keep increasing, you might even be advised to go for an angiogram within 24 hours of
Right.
admission, right? This is on top of your medical therapy. And chronic coronary syndrome is usually treated with medical therapy alone. And depending on the symptoms, whether they need further investigation, it all depends on what is their presenting symptoms.
Okay. So we spoke about angioplasty again. Yeah, Doc, you want to
As
touch?
we have seen in the video, we have to put a stent. And to
Mhm.
highlight the largest vessel in your body, in your coronary arteries, right? Probably the diameter is around 2 to 4 mm. So imagine how small your stent size would be.
Mhm.
So this is your large coronary artery, the three main coronary artery, which is your right coronary artery, your left anterior descending, and also left circumflex. The left side of the heart actually originates from the left main stem. It's one of the biggest artery in your body on the left side, which actually bifurcates into two branches. One is LAD, one is circumflex. So the sizes vary. The largest coronary artery might be around 4 to 4.5 or 5 mm. The smallest coronary artery that can be seen in angiogram also around 2 to 1.5 mm. And we are talking about large epicardial coronary arteries. There's also smaller branches which cannot be seen in angiogram. This is where your MRI or other imaging modality is important to see whether you have any diseases in the small vessels.
Mm. Okay. I think we have a video on this as well. Is that right,
Yes.
Doc?
Yeah.
Okay. Shall we have a look if it's possible?
I think the video is not really playing. Can we play again the video? The first one?
There you go. Good job, Joe.
Okay, so if you can see, this is the angiogram procedure where
Mm-hmm.
we inject the dye into the right coronary arteries, right? From this angiogram, we actually can identify there is a stenosis in the mid segment of the vessel as well as the beginning, the proximal segment of the vessel. So what we decided to do is to open up the vessels, to prepare the vessel to make it bigger, and we implant deploy the stent. So the next picture will actually tells you the results after we put the stent. So you can see the narrowing in the first picture, and now you compare that with the picture, the post stenting angiogram. Now you can see the vessels is bigger,
Mm.
and this is how the stent looks like once it has been deployed in your coronary arteries.
Okay. Very clear. Thanks to the dye, right?
Yes.
Mm. Okay. Shall I go to the next slide, Doc?
Yeah. Please.
Okay, cool. Okay, and this is a bypass, right?
Right. So when we treat coronary artery disease where there's a severe occlusion, as I mentioned earlier, when a patient has multiple occlusions, which is severe, more than 70-80% of blockages, then the option would be to go for one of the options would be to offer a patient a bypass, open heart surgery, which is done by a cardiothoracic surgeon. And this is how it is done by them. And just to illustrate how it is done, basically it simply means you are bypassing the blockages. You are taking vessels from your leg and from the chest. Either you're taking your lima or rima, left internal memory artery or right internal memory artery, and you make a connection from your aorta, the biggest vessels in your body, away from the occlusion, so that now the blood can bypass the occlusion and still flow to the distal part of the artery and supply the muscles there.
Okay, so that's what a bypass means, yeah?
Yeah.
And but basically the mainstay of treatment is what your doc?
Irrespective, you go for a stenting,
Mm-hmm.
or you went for a bypass, or you are only treated medically, the mainstay is still blood thinners. Blood thinners, your antiplatelet is the most important medication you take on top of your cholesterol medication, which is your statins. And of course, depending on your symptoms, some patient, even after going for a bypass or going for a stenting procedure, they might have some minimal chest pains. So we treat them with medication to reduce the chest pain, which is called anti-angina medication. And of course, patient who did not go for this both procedure, bypass or stenting, can also treated with medication alone if their severity of disease is not something that requires an urgent intervention.
Okay, got it. So I think with that, that is our last slide, is it? Yep, that's our last slide, Doc. All done. Okay, so I found this super informative. What was the biggest three things that you learned? Please let us know in the comment section. But with that, I think we can go into the Q&A section, yeah? Kind of thing. Let's go with the first question. Okay, so Rita Liao is asking, is there any possibilities of heart problems for newborn infants? Any symptoms or risk factors? I think definitely got right.
This is totally a different topic
Mm,
itself. The major topic we call is pediatric cardiology, right?
mhm.
Um, there will be a possibility of heart problems for newborn babies where there could be lack of oxygen, they're turning blue and all that. This can be identified as early as newborn or within days or within weeks. So usually doctor will check for certain things medical during their medical assessment to identify them. And some or most of the cases has to be intervened during that period itself because
Okay,
it can be very dangerous for them.
okay, got it. And Momo has a question. Apa penyebab arteri mengecut dan menyempit? Is there any solution selain pembedahan?
So, should I answer this in Malay?
Sure, why not?
Right. Salah satu kemungkinan memerlukan stenting prosedur yang mana kita telah bicara tadi. Kedua, ada banyak ubat yang boleh membantu membaik pulih masalah ini. Tapi pertama kita kena kenal pasti kenapa benda ni berlaku. Adakah berlaku kesumbatan dalam saluran darah? Adakah ini masalah lain? So, yang paling penting perlu berjumpa dengan doktor dan mendapat ujian-ujian tambahan untuk mengenal pasti masalah apa. Adakah ini masalah jantung, dan kalau masalah jantung yang jenis mana? Adakah masalah kesumbatan di saluran darah besar, saluran darah kecil, atau masalah irama jantung atau kerana lemah jantung. So banyak jenis masalah yang boleh berlaku dengan jantung. So kita perlu kenal pasti dengan betul.
Okay, got it. The next questions, I'm going to put it together because I think they're somewhat linked. So Ailian Wang is asking, what are the symptoms? But I think, do you have pain usually daytime or night? I think the chest pain, does it normally happen daytime or night? And this one also is timing. I notice a lot of cardiac arrest cases happen after victims perform certain physical activity like hiking, badminton. So what do you think, Doc? Is the pain usually daytime or
This is
night?
something that I always tell my patients, right? Heart attack doesn't differentiate genders. It can be
Okay.
second thing, it doesn't differentiate time. It can happen early in the morning, late at night, anytime. If it
Okay.
happens, it happens. So the moment you have it, the earlier you seek help helps.
Okay. And what about
For
after
these
it's
questions, there's two ways I see it. Number one is many of us trying to exercise after a period of time, not consistently. So you might not be aware what possible problems you already have before you start initiating yourself into intensive exercise. You may have a heart problem to start off with, which you do not realize. So while you are at rest or where your demand of oxygen that you require is low, you might not have any symptoms. the moment you engage yourself in a very high intensity exercise, whereby badminton, hiking, cycling, and all that, it requires your heart rate to be faster. Your heart rate goes faster when you exercise. So the demand for oxygen is higher. This is where you start to see the problem. Because when
Ah,
there is occlusion or obstruction, there's lack of blood supply and you start to have pain. And unfortunately, some of them do not even make it to the hospital.
wow. Okay. But doc, there's also, these people exercise all the time. Like the Iron Man, I think a lady participant died, right, in Langkawi. They're supposed to be fit because, they take part in Iron Man, they go to the gym and stuff like that. And yet they still have a heart attack. So
There are
a lot of
many
people out there, maybe they don't want
various
to
reasons
exercise
for this.
after that.
As I
So can
mentioned,
you explain?
yeah, like what you clearly state, right?
Uh,
Many of them are fit, but
yeah.
what is a disclaimer to say that
If you're
just
fit,
because you exercise does not
uh,
mean you don't have a problem. So it's
mm,
always good to check because, as I mentioned, there's many things can go wrong with your heart.
mm,
Not necessarily it's just blockages. You might have problems with rhythm,
mm. Okay.
fast rhythm, abnormal, dangerous rhythm. This can also make you to just collapse while
Okay.
you're exercising. So these are the things that you have to check during, or if you intend to engage in competitive sports or high intensity sports.
Okay, got it. So it doesn't mean if you're fit, you don't have a heart problem. It's best to go and check because you never know. Yeah. Okay. This one is a question. Do heart attack have anything to do in connection to lungs? There's a few of these questions actually. It's from Rita.
Basically, I would say everything that related to lung will have an effect on the heart because
Oh, okay.
the oxygen comes from the lung. If you have a
Okay.
lung disease, it actually also predisposes you to have some problems in the heart. But mainly, what do they get is uh, things like pulmonary artery hypertension, heart failure, and many things. But it doesn't directly contribute to occlusion in your blood vessels.
Okay. Got it. Okay. Doc, this one's a question from Momo, which is quite good, I think. Apa yang perlu dilakukan pertolongan pertama untuk orang yang kena heart attack? Maybe there's a step-by-step thing you can give us so that we are clear because a lot of people usually kind of are not aware and they miss that opportunity.
If you're having a heart attack, and if you are in a place where the nearest medical facility is not available,
Mm-hmm.
one, you have to immediately call an ambulance if you
Okay.
think this patient is unstable or very unwell. And if you think this patient is still stable and you can bring him to the nearest hospital as soon as possible, then do it either by yourself or by ambulance. But knowing that our Malaysian traffic is better
Mm,
to go by ambulance if the patient is
okay.
not stable. And let's say this patient having a chest pain, heart attack, and is unconscious, then you have to think about doing a basic emergency CPR or and all these ACLS protocols. This is a different topic altogether. So the most important thing is to identify how is the patient condition. Based on the patient condition, immediately bring them to the nearest hospital,
Mm,
or
okay.
you can call for ambulance to help you.
Okay. And somebody's asking, Rita's asking, does feet massage help do any better to the heart to avoid heart attack? Can
So I would not agree with this statement because so far, I mean, let's talk about evidences here, right?
Okay.
So there's no evidence from the guidelines to say that such massages will help to prevent heart attack.
Okay. Let's go to the next one then. So Jessie Liu is asking, may I think we mentioned things that can clog the blood vessels. So what are the things that can clog the blood vessels besides bad cholesterol?
Mainly, it's bad cholesterol.
Mhm.
The biggest culprit is also is what we call as LDL, your low density lipoproteins, and of course we have also TG, which is triglyceride. These are the components of cholesterol which is bad for your heart. which over the time accumulates in your blood vessel. On top of that, you might have some calcium plugs, which harden the blood clots, which is will be difficult for us to open up later, right? And whenever there's a blockages and there's some inflammation going on, your body's own immune system also involved in this gradual process of atherosclerosis. Just like you rightly put in at the beginning of this talk, when you have a heart attack, it does not happen today. The process have started months ago, years ago. This is
Mhm.
just the end product of it.
Right. Yeah. Okay, got it. And you've got a fan doc. So, Dr. Krish, you are the hero, Rita says, kind of thing. And Rita's question is high blood or low blood lead to heart attack? Is there any link?
Definitely, blood pressure plays a big role in heart attack. And whenever you are having a heart attack, I would prefer someone to have a higher blood pressure than a lower blood pressure. The lower blood pressure simply means the heart is failing, the patient is having a major heart attack, and there's a high chance that it will actually translate into a bad outcome because the heart is might not be pumping enough oxygen, is not giving enough cardiac output, would you say? That is why the pressure is low.
Okay.
So this is actually tells you the severity of the heart attack when patients having a heart attack. So this can be even more dangerous if you have a low blood pressure and while you're having heart attack. That is the first part of the answer, right? If you're having heart attack with a low pressure or high pressure. But what about patients who have low pressure? Would they have a heart attack? The answer would be uh, the heart attack simply means a mismatch of supply and demand. Your
Mm,
body demands oxygen but lack of supply. When the blood pressure is low, there will be lack of blood flow to the heart muscles as well. And of course, that will induce pain, which is your chest pain. So that answers your second question.
okay, got it. So we're gonna go to one more question before we go to break. And that question is from Wang Ailian. When I complained about heart pain, I was prescribed bisoprolol 2.5 milligram daily. I went for MRI. Doctor says nothing wrong and discharged from heart clinic. Do I still continue the medicine and stop taking it? I don't have diabetes or cholesterol, only high blood pressure.
With all due respect, Ms. Wong Eileen, this is something that we cannot give you the answer just from this statement alone. There's many things that we take into account before
Mm-hmm.
we decide whether we need to continue your medication or not. There must be first we need to look through what was the MRI finding and what was your presentation and what was the indication for them, the doctor, to prescribe the bisoprolol. Only then we can decide whether this is something that you need to continue or not. So I would advise to get to seek back the doctor's advice who prescribe you the medication, have a discussion with them whether this is something that you have to continue lifelong or something that you can stop.
Mm, okay, got it. All right, so that's the last question. And now let's go to the quiz, right? What are the questions for the quiz? All right. So before we continue, so it is quiz time, and as mentioned in the earlier part of the show, we've got some amazing prizes, which is a travel organizer bag up for grabs. So who wants to win? Let me know in the comment. But what do you need to do in order to win? First, you got to be sure to share this video out at least 3 times, and remember to set the share post to public so that we can see. Next, answer the 3 questions we'll be showing on the screen in a single comment, and you're on the way to win the prizes. So answer the 3 questions I'm about to ask in a single comment, and you're on your way to win the prize. So are you ready? Let's take a look at the quiz questions. Question number 1 is a heart attack always presents itself with a chest pain. Is it true or false? A heart attack always presents with a chest pain. True or false? Lifestyle changes like a healthy diet and regular exercise can reduce the risk of a heart attack. True or false? Lifestyle changes like a healthy diet and regular exercise can reduce the risk of a heart attack. True or false? And the last question is only older people are at risk of having a heart attack. True or false? Only older people are at risk of having a heart attack. Let us know your answers in a single line. You're on your way to win a travel organizer bag. Let's go back to some of the questions, right? Okay, so Allison, I believe, had a question. Let me put it up here. So, if there is a recurring chest pain that occurs occasionally in a year without the other heart attack symptoms, does it warrant for a concern for any form of heart disease, especially after gastritis medication has been taken a few times, yet chest pain is persistent? How about
I think to answer Miss Allison, if a problem recurs despite the initial treatment, this itself is a red flag for you to
now?
seek extra medical attention. Uh,
So,
from my advice would be to seek medical attention because you have taken medication for your gastritis, but things are not improving. Even if it only happens occasionally, first of all, it should not happen. But if it happens occasionally, this is something that you also need to address quickly before it turns bad. So we
okay.
need to identify what is the cause of the chest pain. Is it cardiac in origin or is that something else going on?
Okay. I think always better to do a check, right? And I think it's awesome that you're getting this warning signs now as opposed to before a heart attack, right? So it's a blessing. Please go and have a look, I would say. Be on the safe side. So next question is from Yvonne Chang Aihua. If someone has a pacemaker, is it more likely for a risk of a heart attack?
Actually, the indication for a pacemaker varies. I'm sure the doctor who implant the pacemaker has a reason, either being a person with a slow heart rate or for whatever reason it be, but it doesn't change your risk of heart attack. To put it very simply, if you have a very high blood pressure and also very poor diabetes control, just because you have a pacemaker that does not prevent you of getting a heart attack.
Mm,
End of the day, controlling all the risk factors is equally important.
mm. Okay. I think that's awesome. Awesome answer. I mean, okay. So next question is from Ara Devaharan. Hi, Dr. Krish. May I know how is dental health linked to heart disease? Is it linked, doc?
Of course, I've mentioned in one of my first slides, many
Mm-hmm.
things can go wrong
Uh-huh.
with heart. One of which is infection in your heart and infection in your heart valves. Someone with a poor dental hygiene who develops some infection in your
Teeth.
dental cavities and all that, there is always a risk that predisposes them to have what we call as infection in your valves, infective endocarditis, which can happen in your infection of your heart, right? And this can
Mm-hmm.
be very dangerous, not easy to treat, requires multiple doctors' opinion and involvement. And
Mm-hmm.
sometimes you need, if it involves the valves and the antibiotic do not work, the patient need to go for a valve surgery for replacement if they have such problems.
Mm. Okay. Right. I think this one, we already looked at this question, but I'll just put it here. What can I do if someone just collapsed due to a heart attack at home and while waiting to be transported to the nearest hospital? CPR? Yeah.
I suppose if you are someone that has been exposed to CPR and also knows the steps of CPR, then this is something that you should advocate while waiting for the ambulance.
Okay. Got it.
Otherwise, it's better to wait for someone who knows, who's been trained to do CPR.
Okay. Got it. Okay. A few more questions. Chia Guat Hua is asking, is there any way the tenting, I think, is that stenting, can be dislodged?
I think the technology is advanced to the fact that when we deploy the stent, we deploy to the size of the vessel. So usually, once we deploy, it actually embedded to the vessel wall, and over time, your body's physiology and all that, the vessel will actually incorporates the stents into the vessel. So there is very less chance of a stent dislodging after it's been deployed for some time. But what can happen is the other two major problems. Over the time, if you don't take care of your medications, and of course, you don't take care of your hypertension, your sugar, your cholesterol, the stents that we put in also can get blocked, which we call as in-stent restenosis. So
Wow.
it is important to remember that putting a stent doesn't give you a lifelong warranty. It
Mm-hmm.
actually prevents the problem at that point. But
Mm-hmm.
what's more important after that is how you take care of yourself and taking medication, regular follow up. This will ensure the stent is patent.
Mm. Okay. I think which is also kind of connected to the next question. What are, if any, the post effects of a heart attack?
When a patient has a heart attack or major heart attack, either the patient make it or don't make it. And of course, how we differentiate or how it happens, it depends on the severity of disease, how soon they are treated in hospital, how soon they come to the hospital after an event, and of course how bad the heart attack to begin with. Is someone who is already have a heart failure, chronic kidney disease, when they have a major heart attack, then the prognosis is not as good as someone who's young, who's fit, or who develops a heart attack because of high cholesterol or quit smoking, because the heart is still strong. And
Mm.
to answer this question in another way, what are the effects of heart attack is sometimes a major heart attack can also lead to heart failure because the muscles, as you remember, some parts of the muscle would have been dead or weak. So this
Mm.
will lead to heart failure. The heart does not pump as effectively as before. And also sometimes it can cause damage to the structures of the heart where they can develop some ruptures of the septum and all that. So many complications can occur after a heart attack. So not only we have to act quickly to establish the flow, but we also need to rule out other complication of heart attack while we treat the patient.
Okay, got it. So we already have our winners, but before that, I'm gonna answer one last question from Jessie Liu. So, with all the tests done, if a person is found to have ischemia, what are the treatments for ischemia?
As I mentioned, it depends on the severity of ischemia, right? But the most important next step would be to perform an angiogram. Number one, to look at the coronary vessel to see how bad the stenosis is, and that will answer your question whether you need to uh, put in a stent to re-establish the blood flow or not,
Mm.
right? But let's say when you do an angiogram and you see the lesion or the stenosis is not severe, but probably moderate in severity, then sometimes we have to, based on the recommendation, we do some functional assessment during the angiogram itself, which we call an invasive functional assessment, where we want to see whether this stenosis or these blockages is significantly affecting the blood flow. Depending on that answer, we decide to put a stent or to treat the patient medically.
Okay, got it. All right, thank you, Doc, for all that questions. I That was really informative for me, and I'm sure for a lot of our people out there as well. So we already have the winners of the quiz, but before we answer the question, let's find out what the correct answer. And Doc is gonna help me with this. Yeah. So let's take a look at the question. So the first question is: a heart attack always presents with chest pains. True or false, Doc?
False.
All right. So it doesn't always present with chest pain. Question number two: lifestyle changes like a healthy diet and regular exercise can reduce the risk of a heart attack. True or false, Doc?
Very true.
All right. So that is true for number two. Only older people are at risk of having a heart attack. True or false, Doc?
Definitely false.
Definitely false. So it is false, true, false. All right. And the winners, the three lucky winners of the quiz are Desmond Hing, Zaini Noor, Rabiatul Adawiyah 2. That's Desmond Hing, Zaini Noor, and Rabiatul Adawiyah 2. Congratulations to our winners. All you have to do is
Congratulations, guys.
Yeah, congratulations. Make sure you check your inbox because we're going to send you a message on how to collect your prizes. All right. Doc, thank you so much for today. I've definitely learned a lot, and I'm sure our people also learned a lot. What was the biggest learning for you? Let us know in the comment. Any last words before we go, Doc, for all our audience out there?
I thank you for the opportunity to spend time with the audience to share some information on coronary artery disease, the importance and all that. I think probably I would close it by saying that the golden words. We always say time is myocardium. Every time that you delay, you might lose a patient, you might lose a loved one or one of your family members or yourself. So it is very important for us to not only take care of our health just by lifestyle changes, but it's also important to take the first big step to go for checkup when you have symptoms. But importantly, even if you don't have symptoms, at least you screen to make sure that you're all right.
Doc, one more, because my own family is like this. Do you find that a lot of people are scared to go for checkups? Just wondering. What
I
do
think
you?
it's true. It's
Yeah.
true because uh, they are worried that when they go for a checkup and they find something, then this is something they don't want to accept. I know it's not easy to accept when something's not right, but
Mm.
it's better to treat it at the initial stage compared to keep it longer or waiting later when things are bad.
Mm, yeah, that is true. And I always think that, no matter how bad you think it is, at least you're still at that stage, one stage up more than finding out later than an
That's
attack. So
very true. That is very true.
yeah. So no
I
matter where
totally
you are,
agree.
you are at least ahead of the curve. So do go and check. It's still going to be the earliest. That's the way I see it. Right. Thank you so much. Thank you, Doc, for an amazing sharing, insightful afternoon. I hope that was very useful to you guys. Now, if you found this information useful, please tag all your family and friends because I thought it makes the difference between life and death, really. And if, like Doc said, we need the awareness kind of thing because heart attack is the number one leading cause of death in the world, right? Not just Malaysia. So thank you so much. Thank you, Doc. Thank you so much for tuning in. That's all the time we have for today. And goodbye and have a wonderful rest of the afternoon from us here at
Thank you,
Brain.
everyone. Thank you, Miss Lina. Thanks.
Thank you, Doc.